session will be chaired by Dr. Amit Vora, electrophysiologist and previously Associate Professor at the Department of Cardiology at KEM Hospital, Mumbai, Dr. V Krishna, Professor of Medicine at Rajarajeshwari Medical College, Bangalore, and Dr. Usha Laxmi, Professor of Medicine at Kilpauk Medical College, Chennai. Kindly proceed to your designated seats. I invite our speaker for this session, Dr. S B Gupta, onto the dais to speak on ECG changes due to drugs and electrolyte disturbances. I request the chairpersons to introduce Dr. S B Gupta.
Dr. Gupta is President of Indian Society Electrocardiology and is in fact the pillar of the society and needs no introduction. So we will go on to Dr. Gupta's deliberation on drugs and electrolytes, how it affects the ECG.
Good afternoon and thank you very much, chairpersons. This topic is of a lot of clinical relevance, and I do not know whether I can cover all the drugs which can cause arrhythmias, and there are lots of arrhythmias which can be caused by the drugs. But I think just to be brief, I think there are a lot of conduction disorders which are being due to drugs, which may be because of the beta blockers or because of the calcium channel blockers like verapamil or diltiazem, digoxin. There are a lot of other antiarrhythmic drugs which can also cause conduction disorders. Then opiates, organophosphates, pesticides, clonidine, and ethanol in a larger quantity can also give rise to conduction disorders. And these conduction disorders can be, I think the basic one is it could be just a sinus bradycardia, and like this patient of hypertension who is also on beta blocker can have a sinus bradycardia. So this is one of the commonest arrhythmia which can happen. And the other arrhythmia, I think it has been discussed by the previous speaker also, that the sinus node dysfunction in the form of either SA block or could be a sinus pause can again be because of these drugs. Any type of AV conduction disorders, maybe it's a first degree AV block, maybe it's a 2:1 or second degree AV block, or maybe the advanced high grade AV blocks, or even a complete AV block can also be because of all the drugs which I have mentioned in my first slide that can lead to these conduction disorders. Then there are certain drugs which can cause sinus tachycardia. It could be drugs like parasympatholytics, like we have talked about atropine or probenthine. Sympathomimetic drugs, whether it's used for like adrenaline, or even the drugs which are used for the relief of bronchial asthma, like salbutamol or any other advanced drugs, can lead to sinus tachycardia. A lot of antihistaminics are there, amphetamine, theophylline group of drugs, or cocaine can cause a sinus tachycardia. Like any sinus tachycardia like this can be caused by the drugs which I have mentioned in the previous slide. I think the most important aspect of the safety of the drugs nowadays, I think practically most of the drugs which are being marketed now have to go under this cardiac safety, whether this drug has got any effect on the QT interval, because the prolongation of the QT interval is a hallmark for a serious fatal or lethal arrhythmia, which is torsade, and which presentation symptom can be a syncope and can lead to a sudden cardiac death. So we have to, I think, very, very careful as far as the prolongation of QT interval is concerned with the drugs. And there is a whole list of the drugs which can cause the prolongation of QT interval. And these are the anti-arrhythmic drugs. There are drugs which have been marked red, which shows these drugs are the top 20 drugs which can cause the prolongation of the QT interval. And the drugs which are starred, have got an asterisk mark, have been associated with torsade very commonly. So the drugs which are there, the antiarrhythmic drugs like quinidine, procanamide, disopyramide, asmeline, ancanide or flecainide. Then drugs like the very commonly used drugs, people use amiodarone left and right, but these drugs can cause a prolongation of QT interval, can lead to torsade. So amiodarone, sotalol, beryllium, ibutylate, duvitylate, and other drugs, and the commonly used drugs, the digoxin. Then again, there are a lot of other drugs like calcium channel blockers. There are two asterisk marks are there, which the drugs which have been withdrawn from the market because of their prolongation of the QT interval and the TOSAD. So the prenylramine, bepredil and terodiline have been already withdrawn from the market. There are, I think, I do not know how many psychiatrists, when they are using the drugs, they know that these drugs can cause prolongation of the QT interval and can even kill the patient because of the TOSAD. There are a lot of, again, drugs, the psychiatric drugs. I think this is the longest list of the drugs which can cause the prolongation of the QT interval. Haloperidol, which is very commonly used by the psychiatrists. The tricyclic antidepressants are very commonly used by the psychiatrists. The SSRIs, which are very commonly used by the psychiatrists, can cause a prolongation of the QT interval. They do not know, and they may feel the symptoms are not because of the drugs, but they can, I think these drugs can kill the patient because of the prolongation of the QT interval and the TOSAD. So there are a lot of drugs which are very commonly used drugs like fluoxetine, very commonly used, doxepin, very commonly used, lithium is very commonly used, the tricyclic antidepressants like amitriptyline, nortriptyline, they are very commonly used drugs, but they can cause prolongation of the QT interval and TOSAD. Then we are using a lot of antihistaminics. Again, just a common cold, we prescribe a drug, again can cause the prolongation of the QT interval. There are a lot of antibiotics which are again can cause the prolongation of the QT interval. Commonly used drugs, even the pediatrician use the erythromycin, the clarithromycin, the ketoconazole, the fluconazole, and quinine, chloroquine, antimalarials, halophantrin, and again the quinolones. Any quinolones can give rise to a prolongation of the QT interval and can lead to TOSAD. So I think when we are using any drug, one should keep that thing in the mind, whether this drug can cause QT prolongation, and then if it can cause QT prolongation, then one has to monitor the ECG. Then I have told you about the serotonin antagonist, agonist, they can cause QT prolongation. Immunosuppressants like tacrolimus, which is being very commonly used by the nephrologist, can cause the QT prolongation. Antidiuretic hormone, vasopressin, and even the very commonly used drug Lasix, furosemide, can cause QT prolongation. The other agents like organophosphates and papaverine, cocaine can also cause QT prolongation. And this is one ECG of quinine-induced QT prolongation in a 45-year-old malaria patient. So just for an example, and this is again an example of very wide QT prolongation in a patient who is being treated by antipsychotic drugs. This is one example of the quinolones which can cause the QT prolongation, and I think on the right hand side, the moxifloxacin and sparfloxacin is one of the important quinolones which can cause a marked degree of QT prolongation. This is one patient who has been survived of the cardiac arrest after the QT prolongation and the TOSAD, and soon after the survival, after the cardiac arrest resuscitation, you can see on the upper strip is the QT prolongation, and after 3 days the QT has become normalized. And this is one example that the QT prolongation can lead to a polymorphic VT or TOSAD. This is one example in which can culminate into a ventricular fibrillation and can lead to a sudden cardiac death. And normally there can be a long and short cycles before it culminates into a polymorphic VT or TOSAD. I think there are again many drugs which I think most of these drugs can lead to ventricular arrhythmias, and the common drugs which can lead to ventricular arrhythmias otherwise also the digoxin, the tricyclic antidepressants, aminophenine or dariphyllene group of drugs, pseudoephedrine, fluoxetine, cocaine, amphetamine, caffeine, alcohol and anesthetics can lead to ventricular arrhythmias, and these ventricular arrhythmias may be single PVCs or could be bigeminy or trigeminy or couplets, triplets, or non-sustained monomorphic VTs can happen because of any of these drugs, or it can lead to even a sustained monomorphic VTs. I think one of the drugs which is again not going out of the way vogue is digoxin. It can give rise to a lot of arrhythmias, and I think because of that reason and because of the increased morbidity and mortality, the drug is not commonly used nowadays. It can lead to decreased AV conduction. It can lead to, I think the sign mark ECG is of digoxin is atrial tachycardia with the 2:1 conduction or 2:1 block. Then it can lead to frequent PVCs. It can lead to sinus bradycardia or slow atrial fibrillation. It can lead to any type of AV block. It can lead to ventricular tachycardia. Digoxin leads to a short QT interval. It can lead to STT or U abnormalities, a prolonged PR interval. Sometimes we say the ST segment is hockey stick type of ST segment or reverse sign. And I think again a hallmark ECG of digoxin toxicity is a bidirectional VT. These are the type of ECG pattern which is being seen in the digitalis toxicity. And one can also have, I think the ECG which was shown by Dr. Martin Green also yesterday, that it can lead to, if we are seeing an ECG of atrial fibrillation with complete AV block, can also, one can think of a digitalis toxicity. And sometimes the ECG may mimic like an ECG of left ventricular hypertrophy and strain, but this is also one of the ECGs which is because of the digitalis toxicity. And this is one ECG of bidirectional VT which can happen because of this is can be because I think this ECG is of bidirectional VT where this is an ECG of bidirectional VT which is because of another drug which is being used by the homeopaths, the aconite, which can also lead to a bidirectional VT, and it can also happen in digitalis toxicity. I think now I'll come to certain electrolytes. I think lot of electrolyte disturbances are there which are happening in medicine, on medical wards or in ICCU, but only electrolyte disturbances which can give rise to ECG changes are mainly because of either the potassium or because of the calcium. And hypokalemia can lead to a decrease in T wave amplitude. It can have a prominent U waves. It can lead to a prolongation of the QT interval. Especially these changes appear when the serum potassium goes below 3 milliequivalents per liter, and similar changes can be seen with quinidine, sotalol or amiodarone. And this is one ECG of the patient who is on a diuretic like indapamide, leading to a very long QT interval and prominent U waves on the ECG. This is because of hypokalemia. The serum potassium was 2.3 milliequivalents per liter in this patient. Then the ECG changes because of hyperkalemia. Again, there are certain characteristic ECG changes in hyperkalemia. We get very peaked T waves which are there from, especially in the precordial leads. We have got a flattened, the conduction disorder starts, then we have got a flattened P waves. There is a prolongation of the PR interval. There is SC segment depression. Then there is a widening of the QRS complex. And finally, we have got a sine wave or M-shaped QRS complex. Like this, what has been shown in red is the M-shaped type of QRS complex. And these, there is a very good correlation usually between the ECG and the serum levels of potassium, and usually the earliest changes they start appearing when the serum potassium starts going above 5.7 milliequivalents per liter, where we start getting a tall peak T waves, and when the level starts rising, then we have got a reduction of the P wave or intra-atrial conduction delay, PR prolongation, and at a higher level then P wave becomes absent, and then the QRS widens, and finally and the patient can go into ventricular fibrillation and the arrest may follow. This is one of the ECG, which is an ECG of 16-year-old girl who was being treated for glomerulonephritis. Especially I think one should be very particular when you are treating a patients of renal dysfunction, especially diabetics, etc., who are on multiple drugs like the ACE inhibitors or ARBs, and sometimes people are giving to relieve the congestion, people are giving aldactone also, and these drugs, all these drugs can lead to hyperkalemia. So one should be very, very careful when we are treating such patients, and one should monitor the potassium, one should monitor the ECG, and you are seeing a very tall tented T waves on this ECG and the prolongation of the QRS complex. So this is one very classical ECG of hyperkalemia. And these are the ECG again of calcium abnormalities. One can have in hypocalcemia, one can have again a prolongation of the QT interval, and the hypercalcemia leads to a shortening of the QT interval. So these are the only changes which are seen with hypo or hypercalcemia. But hypercalcemia, in the state of hypercalcemia, one can have a lot of ventricular arrhythmias, so one should that be aware of. Because I remember one patient whom I have seen, a patient of massive ventricular excess soles. When we evaluated that patient, turned out to be hypercalcemia because of hyperparathyroidism. So just to conclude, we must know the effect of drugs and electrolytes when we are on the ECGs, especially the drugs and electrolytes disturbance which causes acute prolongation and more so causing tossard. Thank you.
Role of glucose and arrhythmias.
Role of glucose,
Hypoglycemia usually
basically
causes
one uses a glucose insulin therapy for treating hyperkalemia. So that is in the role of treatment, but otherwise glucose as such has got nothing.
We have seen so many cases of hypoglycemia manifested as tachycardia.
Hypoglycemia, if one is going into hypotensive state, there is a reflex tachycardia, but as such I do not think that glucose itself causes any arrhythmia. Dr. Amit, you would like to say something?
No, hypoglycemia because of sympathetic overactivity will cause sinus tachycardia. Other than that, I don't think there are any specific changes. Dr. Gupta, I would like to ask you, what is your take on the subject of drug-induced bradycardia? Some of these drugs which are antihypertensives or cardiovascular drugs which are given to patients cause significant bradycardia, either in terms of sinus node dysfunction or an AV block. Would you consider pacemaker implantation and continuation of the drugs, or the drug should be withdrawn and reassessment of the conduction system be done?
I think till most of the time, I think till the patient can is asymptomatic, and if the heart rate is above 50 beats per minute, then I think I would like to continue with the drugs. But if the patient is symptomatic and heart rate is below 50 beats per minute, then I would like to, because there are a lot of drugs which are available to us, we would like to withdraw not to put the pacemaker, but we would like to withdraw the drugs and switch over to the other drug. That will be my way of thinking. But being an electrophysiologist, you can give your viewpoint, but I feel that we know the drug is causing the ECG or the drug is causing the symptomatic bradycardia. So we shall withdraw the drug and switch over to some other drug. That's I would like to say.
Yeah, I think what you say is very logical, but we need to differentiate this, that AV blocks, when they tend to occur and you try to say that this is because of any of the drugs, you need to be a little careful.
Yeah.
More often than not, especially bundle branch blocks and distal conduction system disease don't tend to occur with drugs, and they may be coincident that the patient is on beta blocker and not that the beta blocker or the calcium channel blocker has been responsible for the distal conduction system disease. Should not mistake that.
Yeah.
You can get also AV nodal blocks with these drugs, and there has been a report also, and we've realized that this also acts like a pharmacological challenge test to the conduction system, and the conduction system is already partly sick, and with these drugs it manifests into a significant bradycardia, and more often than not these patients on a follow-up are going to develop full-fledged conduction system disturbance requiring pacemaker therapy. So with AV conduction we have a lower threshold in offering pacemaker as a solution to the bradycardia, but you are right that in terms of sinus node dysfunction you always have a room to play wherein you can stop the drug, use an alternative drug, see whether what kind of conduction bradycardia remains, and then take a decision whether you would want to offer a pacemaker.
And I think all these drugs basically, if some more of a distal blocks, then likely it's not going to revert, and these may require the pacemakers if it's a distal block, but if it's a AV nodal block, then most probably it might revert back.
Excuse me.
I'm Dr. Muhammad Ismail. My question to you is, the drugs, particularly the fluoroquinolones, which we use every day and night, do you think it's idiosyncratic or a dose dependent, which gives rise to the torsion de points or QT prolongation?
It's not dose dependent. One thing is because the certain drugs have got more pronounced effect on the QT interval, so it's not dose dependent. But a lot of patients we are using, so only in few patients we get this problem. But one should be aware of the person is complaining of, suppose somebody is on these quinolones, and if some complains of syncope or gets a seizure, one should be aware of this problem and should try to monitor the ECG without or consulting a neurologist. So one should be aware of it can be because of QT prolongation and can be because of the polymorphic VT.
Sir, with the number of drugs that you have shown which would cause QT prolongation,
a very few number of drugs.
Now, do you feel that before putting on these drugs that we have to do an ECG on everyone?
I don't think that can be done, but one should be aware of the situation. If a person develops any symptom which is suggestive of that patient is having a dizziness or syncope, I think one should do an ECG. So we are treating a lot of malaria patients. We are not doing an ECG in each and every person. But if somebody is complaining of some dizziness or syncope, I think that's the time one must do an ECG, and one shall not just take it that this may be just because of malaria or any other.
One question is, among the listed drugs which is producing the QT prolongation, we quite commonly use the drug for the angioplasty. Among the list of the drugs, one of the drugs you mentioned that sirolimus or the sirolimus derivatives. We do this drug for the drug-eluting stent for the angioplasty patient. Do you have any stake on that? Whether should we condemn the sirolimus drugs for the angioplasty? Once it has been implanted in there, at least 6 months for the drug to be deleted from the body system. Do those individuals are prone to get this QT prolongation?
I think the tacrolimus which is being placed in the stents is a very small quantity, and I don't think any report has been mentioned as far as tacrolimus eluting stent leading to any prolongation of the QT interval. But I have mentioned that these drugs is used in quite a higher doses by the nephrologist. So there I think one should be careful.
But for the QT prolongation, there are certain drugs are dose dependent rather than the single dose or whatever the less dose. Is that true, sir?
Because tacrolimus is more of dose dependent.
Thank you. Thank you, sir.
Today we use a lot of macrolides with antihistaminics. I want your comment about the safety of these two combinations and what are the ECG changes that they can produce.
I think both I have mentioned can lead to a QT prolongation, both the things. So one shall use safer antihistaminics.
Which one? Which antihistaminic is safer? Because there are so many antihistaminics that are available today, right from selective, non-selective, along with macrolides. Because viral infections, so many things, upper respiratory tract infections are all treated with macrolides, with antihistaminics. So
again, I think erythromycin has been shown to prolong the QT, but the other like azithromycin or oxythromycin have not been in the list, number one. Similarly, the levocetirizine is not in the list so far. It may be coming in the list in future, but so far they are not in the list. One can use the other macrolides and the safer antihistaminics.
Thank you.
And to emphasize the need of a wholesome approach is very important. Because I just want to reiterate a case that I came across. In a setting of a patient with coronary artery disease, she had a prolonged QT which was not recognized. And if at all, it was not recognized as an electrolyte imbalance. And people were thinking it was IHD, CAD. And then finally the patient had a hypocalcemia. Only when the patient clinically had a tetany and then tetanic seizure, they realized it was hypocalcemia, and only then the test was done. So here I just want to reiterate the wholesome approach just not when a person is having already a history of some disease, it doesn't mean there can be other comorbid conditions, especially electrolyte balance, hypocalcemia. Also, magnesium has to be estimated in such a clinical setting. And that patient actually had an infarct when that patient went in for a tetanic seizure. So the you have to emphasize regarding drug history, and we have to recognize electrolyte imbalances. This is a point that I wanted to say.
Thank you.
And we thank
you
S B Gupta for his a good speech, enlightening speech. Thank you.
Thank you, sir. I request Dr. Amit Vora to felicitate Dr. S B Gupta. And I request Dr. S B Gupta to hand over the certificates to the chairpersons.